Our first session is the psychological impact of discrimination on Muslim healthcare workers during COVID-19. And it's going to be presented by Kamal Suleiman, who is an undergrad student at University of Pennsylvania and a research assistant at Stanford Muslim Mental Health Lab under Dr. Rania Awad. And I can see Dr. Rania Awad in the hall. Welcome, Dr. Awad. We're glad to have you here. And we have the second presenter is Dr. Lana Abdole, is a resident at Henryford Hospital. So guys, the stage is yours.
Assalamu alaikum, everybody. I'm Lana Abdole. I am a first-year psychiatry resident at Henry Ford in Detroit.
Assalamu alaikum. My name is Kamal Suleiman, and like I said, I'm a senior at the University of Pennsylvania.
And our project came out of the Stanford Muslim Mental Health Lab in Islamic psychology, so special shout out for all their help and support. Our team has no conflicts of interest to report or disclose. In our presentations on the psychological impact of discrimination on Muslim healthcare workers, specifically during the COVID-19 pandemic, this project was part of a larger scale survey and project in collaboration with the Stanford Muslim Mental Health Lab, as well as the Institute of Social Policy and Understanding. So a little bit of background. As we all know, COVID-19 has been a pandemic that's been ongoing, especially in the past 2 years. Specifically, healthcare workers have reported increased distress, anxiety, and decreased well-being since the pandemic has occurred due to being front lines and the risk of social isolation, as well as risk for sickness. Beyond the work environment, healthcare workers have faced increased social isolation and disconnection. This is particularly important for the Muslim community, given that we are very much a community-oriented society. And this social isolation has been shown to have significantly worse mental health outcomes. Outside of COVID-19 in general, discrimination in the healthcare workplace for marginalized communities has always, discrimination has always been an additional stressor. So looking at our specific population, which is the American Muslim healthcare workers, they have this compounded stress of the pandemic, additionally with the ongoing discrimination stress that they face in the workplace. So our particular study is kind of looking at the discrimination part during the ongoing pandemic. So just general background on just American Muslim healthcare workers. It is a very limited, there's very limited research in this area. Some research has shown that Muslim healthcare workers who perceive discrimination in the workplace do report lower job satisfaction as well as higher turnover rates. Additionally, there's a lot of anecdotal adverse experiences. So a lot of social isolation in the workplace from coworkers post 9/11, additional scrutiny in the hiring process, as well as in the residency match. There's refusal of care from patients due to discrimination. And all these implicit biases have led to increased job turnover, as well as difficulty reaching like promotions, as well as a diminished sense of belonging in the workplace for Muslim Americans. And as I said earlier, this is an understudied population. So little is looked at whether there's what coping mechanisms are used for stressors in this population. So we use this opportunity in our project to look at this. And it's just interestingly of note, there are studies outside of America that looked at Muslim populations such as those in the UAE during the pandemic. And in those papers, they have been shown that Muslim healthcare workers in those countries use positive coping strategies, and that was a protective factor for their mental health. But there's very limited data and research into non-Muslim countries. So kind of looking at our goals for this project, we're looking at the discrimination, the perceived discrimination of American healthcare workers and seeing how this impacts their psychological distress, as well as looking at what coping mechanisms they used during those times of stress. And this is just also to remember, the data was collected during the time of COVID-19. So it's looking at discrimination, but during the time of additionally the stress of COVID-19. So I'll let Kamal talk about, before we change to methods. Just Some information on coping and the definition we used. So coping was a behavior a person partakes in or a belief a person relies on when dealing with stress, whether consciously or unconsciously, as an attempt to relieve their negative emotions. So you have, the cognitive side of coping, which is more thought-based or thought-based or belief-based. And then you also have the behavioral component, which is more of an action, such as journaling. And then you also have adaptive coping mechanisms and maladaptive mechanisms. So for adaptive, this would be something that promotes well-being, while maladaptive impedes well-being and has been shown to have poor outcomes in mental health for those who cope in a maladaptive way. And now I'll move on to methods.
Jazakallah khair. Yeah, so like she said, we want to talk a little bit about how we chose to approach achieving the goals of our study. And so our study design, we chose to do a cross-sectional online survey study that we fielded utilizing various social media platforms, as well as different community partnership organizations that were focused around ethnic affinity groups, interest affinity groups, and religious affinity groups as well. And we were particularly looking for Muslim identifying healthcare workers who currently work inside of the US. We were finally able to recruit a sample size of 692. And we are going to be presenting 3 of the variables that we collected as part of this larger scope study during this presentation. Those 3 variables were psychological distress, the frequency of experiencing discrimination of various types, and the utilization of coping strategies of various types. And so we'll get into how those were measured. For psychological distress, we chose to use a psychometrically validated scale called the Patient Health Questionnaire. In particular, we used a truncated, very efficient form of it called the PHQ-4, which has 2 subscales within, with a total of 4 questions. So there is a depression subscale that has 2 questions, as well as an anxiety subscale. And each of these are measured using a Likert scale that assesses a self-reported frequency of experiencing those feelings over the last 2 weeks. And when you combine the scores for those Likert scales, you get a generalized factor called psychological distress, using which you can apply thresholds for various outcomes. So a score of 0 to 2 would be no psychological distress, 2 to 4 would be mild, 6 to 8 would be severe, so would be moderate, and 9 to 12 would be severe psychological distress. And so you'll see those terms returning as outcome variables when we talk about our analysis. For discrimination, we did not use a psychometrically validated scale. Instead, we used a series of self-report items. For example, outside of your workplace, how often, if at all, have you personally experienced discrimination in the past year because of your religion? We did within your workplace because of your religion, within your workplace because of your race, and within your workplace because of your gender. And once again, these are measured on a Likert scale based on self-reported frequency of experiencing those forms of discrimination. And for behavioral coping, we assessed 11 different coping strategies. Of these, there were some that were of a religious nature, some of a non-religious nature, and some that we labeled as healthy and some that we labeled as unhealthy. And so 3 of them were religious in nature: extra prayer or salah, reading Quran, and extra dua or supplication. The rest were unhealthy. And then for those that we deemed the rest were non-religious. And for the ones that we labeled as healthy were all 3 religious variables: so extra prayer, reading Quran, and extra dua, as well as journaling, calling friends and family, and exercising. And the remaining 5 we labeled as unhealthy: so shopping online, utilizing tobacco products, sleeping more than usual, drugs and/or alcohol, and eating comfort food. Now would be a good time to make a disclaimer that those that we label to be healthy or unhealthy are not inherently in and of themselves unhealthy or healthy. For example, the ones that we labeled as unhealthy, for example, sleeping more than usual or eating comfort food, can be neutral in a lot of contexts. But we wanted to make these distinctions based off of our surveys of the literature that suggested that these are behaviors that are generally associated with extra risk for avoidance behaviors or addictive behaviors. And those that we labeled healthy, similarly, could also be unhealthy in some cases. For example, exercising in some eating disorder context could actually be detrimental. But again, this is based off of our survey of the literature for general factors that either promote well-being or impede well-being. For cognitive coping, we assessed 6 different thoughts, and all of these were actually of a specifically religious nature. However, 3 of them we labeled as healthy religious coping thoughts. So this would be telling myself that suffering may bring me closer to Allah, looking for a lesson from Allah in the situation, trying to remember my blessings and thank Allah. Those are our 3 healthy religious coping thoughts. And the other 3 we label as unhealthy. So feeling angry with Allah, losing my faith in Allah's wisdom or compassion, and wondering if I'm being punished by Allah. And so these coping strategies, as well as the behavioral coping strategies.
Stop it. People cannot see the screen on the Zoom.
Oh, really?
Yeah. So
Okay.
sorry about that.
That's a good idea.
Everybody can see that now?
Finally.
Okay, thank you.
I'm so sorry. I wish we knew earlier. I can do it. It's okay. Thank you guys for catching that. Yeah. Yeah, so this is the assessment of all the coping strategies that we looked at. These were also all assessed according to a Likert scale of self-reported frequency of utilizing those different coping mechanisms. And so for our statistical analyses, I'm going to move this bar. Boom. Is my face coming up in it even?
Yeah, it was just
Oh, sorry. Okay, so we used several multivariate logistic regression models that were developed using Stata 15.0, and all the models were controlled for race, gender, and age. And using these models, we produced relative risk ratios. And so the independent variable in these risk ratios was the frequency of experiencing the different discrimination factors. And the dependent variables that we assessed were psychological distress, either mild, moderate, or severe, and coping strategy utilization of religious, non-religious, healthy, or unhealthy nature. And so what a relative risk ratio basically means is that using that independent variable, so based on somebody's reported frequency of experiencing discrimination, how did that increase their risk of participating in one of the dependent variables? So how did that increase their risk of psychological distress, or how did that increase the likelihood that they would utilize a particular coping strategy? And so this is the nature of the results that we are now going to present.
All right, for our results, I'll be highlighting some of the statistical significant ones just to not get lost in all of the data. Tried to make it as simple as possible looking at the chart. So at the top, you have mild psychological distress and moderate severe psychological distress. And this particular table is discrimination, perception of discrimination and dissociation of psychological distress. And then on the left, you have discrimination and the different severities. So looking at the first one, people who reported perceived Islamophobia outside of the workplace and racial discrimination within the workplace were 5 times more likely to have mild psychological distress and 6 times more likely to have moderate to severe psychological distress. People who reported perceived Islamophobia outside of the workplace and gender discrimination within the workplace, these values were elevated, but not significantly so. Those who perceived Islamophobia outside of the workspace and within the workspace, as well as racial discrimination within the workplace, were 5 times more likely to have moderate to severe psychological distress. And then those who reported any combination of the 4 above were 5 times more likely to have mild psychological distress and 9 times more likely to have moderate to severe psychological distress. This next table is looking at discrimination and coping strategies utilized. So as you can see on the top row, we have the different coping strategies. So healthy non-religious coping, healthy religious coping, unhealthy non-religious coping, and then unhealthy religious coping strategies. And this first table is specifically those who perceived Islamophobia within the workplace, and then how often they perceived it was rarely, occasionally, or regularly. So kind of going through each one. Which it's not clicking. There it goes. So those who reported rare Islamophobia within the workplace were more likely to utilize healthy non-religious coping strategies. Those who reported occasional Islamophobia within the workplace were more likely to use healthy non-religious coping strategies. They were also more likely to utilize healthy religious coping strategies. These numbers were insignificant. And then what was interesting was those who reported regular Islamophobia within the workplace were actually less likely to use unhealthy religious coping strategies. Now this table has the same coping strategies above. This particular table is looking at racial discrimination within the workplace. So those who rarely perceived racial discrimination in the workplace were interestingly less likely to utilize healthy non-religious coping strategies. And the other interesting fact was that those who reported rare and regular racial discrimination were more likely to utilize unhealthy religious coping strategies. So kind of to put these two together, So these tables are kind of the combination of the two. It's interesting to see that those who perceived Islamophobia were more likely in general to utilize healthy coping strategies, both religious and non-religious, but they were less likely to utilize unhealthy religious coping strategies. When looking at the racial discrimination one within the workplace, they were less likely to utilize healthy coping strategies, but they were more likely to utilize unhealthy coping strategies.
Yeah, so we want to get into a little bit of discussion after looking at all those numbers. We want to see kind of how it is that we can try to interpret some of these findings. But to start with a short summary, once again, just to reiterate, thank you again. So for our first independent variable of religious discrimination, we saw that it increased risk for psychological distress. And we also found that it increased the likelihood of utilizing healthy coping strategies, particularly religious ones, and it decreased the likelihood of utilizing unhealthy coping strategies. And for racial discrimination, we actually saw contrary findings. So it saw that psychological distress was once again increased. However, they were actually, the likelihood of utilizing healthy coping strategies was decreased, and likelihood of utilizing unhealthy coping strategies was increased. And so it can be interesting to try to situate these findings within the broader literature. So to begin interpretation, previous literature has suggested a bidirectional relationship between religious discrimination and religiosity. And so kind of this idea of a negative feedback loop in which religiosity can actually impact discrimination, and discrimination may actually impact religiosity. So to start with the left leg of this model, you see that religiosity, some factors, for example, there's literature to show that those who report having a high level of religion being important to their daily life may actually label some ambiguous events as discriminatory based on their identity. And this is true for various types of discrimination. Additionally, those who are more religious may actually demonstrate or display more religious identifying factors like hijab, which opens up their risk for facing different forms of discrimination. And then to look at the other leg, you see that how discrimination, this is more sparse literature, but it's still interesting to think about how facing discrimination may actually impact somebody's religiosity levels. So for example, those who face discrimination related to their religion may actually open the door for them to use their religion as a source of coping strategies to deal with that stress itself. And additionally, those who face discrimination, that may actually result in them having an increased strength in their identity when they return back to their in-group to seek support as a result for other people who may have common experiences or other people who may be able to support them in unique ways. And so how do our findings fit into that? Our results can sort of contribute to this conceptualization, especially given the high self-reported religiosity of our sample. So for some context about our demographics, you see in this chart, more than half of the participants in our study reported religion to be extremely important to their daily life. And if you look at the chart, if you incorporate very important, that goes up to about 90%. So it's a very, very self-reportedly religious sample. And so thinking back to that model, you can imagine that this high religiosity may sort of help explain the perception of Islamophobia in that group, whether that could have been a result of them being more likely to label ambiguous situations as a result of their identity, or through being more likely to display religious identifying factors. And simultaneously, that high religiosity may have supported the utilization of healthy coping strategies. And if you remember from our findings, this is especially true for increasing their likelihood of utilizing religious coping strategies and decreasing their likelihood of using specifically unhealthy religious coping strategies. And so to go back to this model, we specifically want to argue that our findings kind of contribute to the literature on this right leg, showing more support for the concept that facing discrimination may actually have a significant impact on an individual's religiosity in those various ways. And so this is some potential context for our findings about religious discrimination. However, the impacts of racial discrimination on coping in our sample, how they were sort of contrary, are much more difficult to explain. And so what we thought would be best would just be to suggest some future research and areas that it should investigate in order to help us to possibly explain some of our findings and also see if they might be replicable in other scenarios as well. And so one interesting question would be, what are the factors that impact an individual's perception of discrimination as either targeting their race or their religion or both, right? So people who experience possibly the same event, how do they attribute that event to one of their various identities? And this would be particularly interesting for those from marginalized races. For example, Black or African American Muslims are at really elevated risk for experiencing both racial and religious discrimination. And so how are they delineating between those two, if at all? Within that, it might be interesting to look at sort of the voluntary nature of religion and the involuntary nature of race, and how that might be impacting people's cognitions about the experiences that they have, and how that might be impacting their likelihood of either positively coping or negatively coping. Another interesting question would be, what aspects of those experiences lead to the utilization of different healthy and unhealthy coping strategies? Another interesting question would be, what can be done to promote the utilization of healthier coping strategies when an individual is experiencing racial discrimination? So if we are able to find that these are replicable findings in various scenarios, then the next question would be, If it's true that facing racial discrimination might increase risk of maladaptive coping, how can we seek paths to remediation for that problem? We want to talk about some salient limitations to our study very quickly because I know we're short on time, but there's a self-report bias as a result of a survey study, and also we use convenience sampling. For example, highly religious study, most likely it was a result of our convenience sampling, and so that limits the generalizability of our study. And also we want to mention that we do not utilize psychometrically validated scales in some contexts, and so there's a lot of reasonings that go behind that. For example, the scarce literature on this topic. Also, there were a lot of unique considerations related to the COVID-19 pandemic and the particular experiences of the population. And so given that there's not a very, very robust literature about this, we felt like we wanted to find ways to measure coping strategies in particular that would be particularly relevant to this population. And so we developed these items in consultation with experts in the field of social science and medicine, many of whom shared a Muslim identity with our population, in order to construct items that we believe were particularly relevant to this population and circumstance. But we definitely want to note that this impacts our analyses quite significantly. And so just the potential implications to repeat that Muslim healthcare workers are facing a significant risk for adverse mental health outcomes because of COVID and discrimination. And existing research offers pretty limited understanding of how Muslims in non-Muslim majority countries are coping with that distress. And so this helps by expanding our understanding of how Muslim American healthcare workers are reacting to these stressors. Our findings contribute to the development of more robust recommendations for system-wide support and individual self-care among American Muslim healthcare workers. Jazakumullah khair for listening to the presentation.
Thank you so much for that presentation. If any of you have questions, I suggest you write them down, and we'll get to them at the end, inshallah, after the rest of the presentations. And those of you in the chat who have questions, please also do the same. You can put it in the chat, and we'll get to those too. So our next presenters are Dr. Shamaila Khan and Dr. Tahirah Abdullah. They'll be presenting on the double edge, working through the COVID-19 pandemic and the racial pandemic towards helping those who are vulnerable while holding our own vulnerabilities. Just a introduction for Dr. Shamaila Khan. She's a licensed clinical psychologist and an assistant professor at the Boston University School of Medicine, Boston Medical Center. She's additionally the training director of the Center for Multicultural Training in Psychology and the director for the Center for Multicultural Mental Health at BU. Dr. Tahirah Abdullah has a PhD in clinical psychology from the University of Kentucky and is an associate professor of the University of Massachusetts, Boston. She's also core faculty at the Center for Multicultural Training in Psychology at Boston Medical Center, BU School of Medicine. You both have been made moderators or co-hosts, so you can share your screen whenever you're ready to present.
Thank you. Assalamu alaikum, everyone.
Actually, one moment, please. Let me go back. Yep. Okay. Please go ahead.
Assalamu alaikum, everyone. I hope you can hear us okay. We're sorry that we can't see all the participants who are in the room there, but we'll try to do our best to engage in some form. So I think our presentation is going to be partly building on what the previous presenter.
Excuse me, Dr. Shamaila, do you think you can talk a little bit louder?
Sure.
Can
Can you
a
hear
little
me
bit louder?
Is that better?
Yes.
I was just stating that our presentation is likely going to be building on some of the content that was shared in the previous presentation. I know that we've been introduced, but we would also like to add introductions in terms of our personal identities. I'm Shamaila Khan, and I identify as a Pakistani American Muslim cisgendered married woman with who's a mother of a 5-year-old. I have lived in 3 different continents and speak 7 languages, and issues of multiculturalism, diversity, and social justice are at the core of my personal and professional identity.
And I am Tahirah Abdullah. I am a Black African-American cisgender Muslim woman. I am from the US South, which has really shaped a large part of my identity, and currently living in Boston. Like Dr. Khan, I also have a deeply rooted commitment to social justice that influences all of the work that I do and is tied to me, both personally and professionally.
So you've heard our introductions, and we believe that, the reason why we share our personal identities is because as clinical psychologists, we believe that, we are the agents of social change. And if we are going to be working with people, since we're the agents of change, we ought to be sharing that aspect, because that is what informs our work. Our values are embedded in our identities, and that's an important part. And both of us are, clearly committed to social justice and passionate about multicultural diversity related work. We both identify as BIPOC. We both identify as women of color. We both identify as being Muslim. So those have shaped our commitments and the kind of work that we have done. So what we'll be doing is that we'll be sharing briefly, very quickly, the historical context and data, which develops on the previous presentation, and then we'll be sharing more from an experiential space, talking about the kind of work that we have done and what it means to be serving the vulnerable population while we are vulnerable ourselves based on our identities and the marginalized aspect of our identities particularly. And we'll share the lessons that we have learned.
So starting off with some historical context, I think that some of the things that are really important to mention in the context of both of the pandemics that we're talking about are, first of all, the history of movements in resistance to racism that have occurred in this country. So there's a legacy of movements resisting racism, and what we've seen in 2020 and beyond is a continuation of that legacy. And similarly, there's a history of obviously racism and of racism-related stress and racial trauma and police violence against Black Americans. And what we've seen in 2020 that's been really highly publicized is, again, an ongoing piece of the legacy of that violence and that trauma. Other pieces that are important in terms of the context for the COVID pandemic and how that pandemic has impacted Muslims and people of color more broadly is that there's the aspect of social determinants of health, right? That not only the piece of racism and discrimination, which we'll talk about a little bit more, but also the myriad social determinants of health that have exacerbated the disparities that we've seen in COVID for Black, Latinx, Indigenous, and immigrant communities who have all been disproportionately impacted by COVID. In terms of mortality rates, in terms of morbidity rates, and in terms of overall impact in an economic and social way as well. The discrimination is also an important piece of the historical context that has served as the backdrop for the work that we both do. 60% of Muslim Americans reported experiencing religious discrimination in a study from 2016. And that discrimination really is critical to consider when we think about the work that we do as health and mental health care professionals. The discrimination that Muslims experience and that people of color more broadly experience contributes to the mistrust of social systems, including health and mental health care systems. So the discrimination, which is part of the general historical mistreatment, contributes to this mistrust. For Muslims and for people of color more broadly, there also are surveillance concerns. If we think about the post 9/11 surveillance of Muslims, there's been a lot of mistrust that connects with that as well. It's understandable to not want to be tracked, right? To not want to have your medical information be reported, or to not have concerns that you might be bringing to a mental health or a medical professional be reported outside of that space. And so surveillance concerns and concerns about the way that information that is being brought into the healthcare or mental health care room is being used can contribute to that mistrust. And all of these concerns can impact ability to access care that is actually going to be beneficial for people.
So there's just some recent data, given that this is from our local, some of it is from here in Massachusetts, we're talking about the discrimination aspect of it. So we're highlighting the race aspect, we're highlighting the socioeconomic aspect, and then we'll be highlighting the religious aspect as well. So you can see that Black and Indigenous Americans experience highest death tolls from COVID-19. And this is data from just 2020, and I'm sure it's expanded since then. But you can see that the rates are far higher for the Black and Indigenous American populations when it comes to death tolls. And when we look at this Harvard study, looked at the inequities in regards to these deaths, right? People living in the most disadvantaged counties have the highest COVID death rates. So these are all interconnected aspects, right? So you can see that by poverty, that's the highest rate is at 19.31. Similarly by crowding and by population of color. So people of color, BIPOC individuals, those living in poverty are also living in crowded areas often, and those are the most impacted. And if you look at the religious aspect of it, right? So data that was gathered shows that compared with the Christians, all religious groups had an elevated risk of death involving COVID, but the largest was for Muslim and Jewish men, respectively. Those affiliated with no religion had the lowest risk of COVID. So it's interesting, given that religion can also be a coping mechanism, but there's more detail that speaks to that within the study. The probability of being infected or dying from COVID varies depending on a variety of factors, including SES determinants, of course. So you can see that age was a factor, which we've known, and COVID-related aspects that the age plays a role in terms of how one deals with COVID. One's geography, where they live, that makes a difference. Socioeconomic status makes a difference, and household variables. So there are multiple aspects that are related to our social demographics and identities that make a difference in this regard, right? So there's a conversation about the fact that communal religious prayers and cultural factors such as contact with large extended families and strong community links are considered factors in the spread of COVID amongst religious communities. But I just want to note the fact that, although those are aspects that may contribute to transmissibility of it that's higher, those are also the factors that lead to support. Coming from these factors, religion is an aspect of support, and communal gatherings and religious prayers are an aspect of support and well-being, and so are the links with families and strong community connections.
So we each wanted to take some time to share a bit about our experiences and the work that we've done as Muslim women of color clinicians during these pandemics. And so for me, as I mentioned at the outset, in addition to being Muslim, am also a Black and African-American woman. And in 2021, I was living in Louisville, Kentucky, and I was down there during the time in the aftermath of Breonna Taylor's killing. And the work that I was doing at the time was at a university counseling center. I was working at Spalding University, and a piece of my work, in addition to being a clinician in the counseling center, also involved working with the student affairs branch of the university and other, aspects of the university as they were trying to develop and determine what the response was going to be, given whether or not the grand jury was going to bring back any indictments to hold the officers who were responsible for her death accountable. And as a Black woman, being part of those conversations for me was both an opportunity for me to really work on something that I was hopeful would be moving things forward, but also brought up a lot of my own emotions, brought up a lot of pain, brought up a lot of stress for me. And so having to hold both my own experiences in those moments and through those conversations, as well as the experiences that my clients were having, was, not a completely unique experience, but felt especially salient in those moments of living in that city and of experiencing firsthand, the protests that were happening, of feeling really connected to all of the pain and feeling really connected to all of the desire for change and the motivation for change. And so while the advocacy piece was really necessary to work towards preparing responses that were going to be supportive of the university community during that time, it was also really important for me to make sure that I was able to care for myself and do the work that I needed to do to be able to work with the individual clients that I was working with during that time. One of the other experiences that I have been having over the course of the past couple of years has been the opportunity to work with Codman Square, which is a neighborhood in the Boston, within Boston in the Dorchester, a sub-neighborhood in the Dorchester neighborhood of Boston. And it's a predominantly Black neighborhood. And I was approached in the summer of 2020 and asked about providing a well-being gathering for the community virtually. And part of this reasoning for this was that there was a real need for connection. A lot of the community members were older and weren't feeling as connected as they had been to their communities. And so I held space, facilitated the gathering, and was invited back on a monthly basis. And now it's been an ongoing thing over the past couple of years that I've been doing. And one of the things that came from this was an uncovering of deeper and more ongoing needs, that it wasn't just the need for this connection during COVID, but what we've also come to realize is that there is a great need in terms of not just mental health care and well-being care, but also being connected to resources and being in this space and able to provide the services that I'm providing through these gatherings has also enabled me to get a deeper understanding of those needs and to come up with creative ways to think through how we can actually address the more ongoing and deeper needs of the community. And other aspects of work, I have a consulting company, Bear Mental Health and Wellness, that I've also been called on for expertise and for talks around racial trauma, around healing from racial trauma, around diversity, equity, and inclusion.
So I know that I'm going to talk next, but I'm also recognizing the time limitation. So we'll try to cover the next slides fairly quickly. And as you'll note, we're calling it the pandemics. So we're obviously talking about the COVID-19 pandemic, but also talking about the racial pandemic, just for clarification. So I've done a multitude of things during which I'm working with people of color as well as Muslims. And the work has impacted me in terms of helping as well, where I'm with communities of individuals whom I can relate with and who can relate with me. So one of the things that we have done is started a family support center through a grant at the Boston Medical Center. So we were recognizing, I was part of the crisis team following the pandemic. So lots of people who were coming in who had family members who were hospitalized there, they were dying and family members could not connect with the patients. So what we did was we started a family support center to help them with this process. So individual therapy, group therapy, family grief conversations, bereavement services, resources, trainings of all kinds are provided through this family support center. It particularly became apparent in regards to some of the Muslim families, the burial aspects of what were very complicated, and how the idea of not being able to bury a family member within 24 hours as required by faith was not a possibility, and not being able to be with members who were lost, not being able to be part of the burial process was pretty complicated. In the meanwhile, I had lost family members. And so it's further compounded, unlike other crisis interventions and situations where we're working with a population that's impacted, but we are not part of it. Here, we're all impacted as providers as well. So we have to be mindful of what we're doing and to what extent we can offer these and how we're impacted and how that impact is then taking a toll on the work that we do. The other part of it was working on the pandemic triage team, which is a crisis teams in the front lines and providing services for them, but also looking at health disparities that come at play within that. As part of the ethics team, which is the allocation of resources. So this is, when the rates were really high and where was lack of oxygen in the hospital system, and figuring out who gets those services and making sure and ensuring that there were no biases in terms of how those items were distributed. Part of that equity advisory group, inclusive pedagogy group, I'm chair of the diversity inclusion committee. So all of these, I'm not going to go in detail with all of this, but all of them focus on making sure and ensuring that our vulnerable populations are taken care of. 5 minutes. Thank you, Sana. I'm just going to leave this aside and just speak to it overall in terms of all these things, and how what has been meaningful is to be in space with others who are also experiencing something similar. So I've collaborated with the Islamic Society Boston Cultural Center, and so you get direct referrals of individuals who are needing support, who can easily surpass the waiting lines that are in mental health systems that are in place. So all sorts of equity and support services that are built in due to vulnerability of individuals. Next. As you know, that the whole world is suffering, and Muslim Americans are at a disadvantaged group, and that they are hardest hit by the pandemic. They're likely to be the frontline workers and lack of access to proper healthcare and have no cash or credit cushion. This is all data that has been gathered from research, and some of it is from the ISPU data that we gathered. And that spiritual nourishment can be lasting on people's mind in one way, but at another time, like when it is an uncertain time, people do seek that as a support measure as well. Did you want to talk about that? Suspension of the communal worship. So there were closures of places of worship, and families could not be in their community during rituals of Ramadan, the collective prayers, the celebration of Eid. The Hajj was severely impacted. We noticed a lot of vaccine hesitancy in regards to vaccine hesitancy during Ramadan was very apparent. So a lot of the work that we did, we as a Center for Multicultural Mental Health went and spoke to different communities about the importance of this. I think it's what the distrust that exists, it counters that, because when you're speaking as a person of color to other people of color who have done this, it's heard differently. So a lot of work was done around that as well.
And, as Dr. Khan talked about earlier, despite the social distancing, there have been lots of efforts to maintain connection and community. And ISPU's survey responses showed that mosques, religious leaders, and community organizations worked really hard to create spiritual and communal communities virtually, which has been really, really important. And also, community is at the root of healing, which has resulted in new forms of community mobilization to provide care, whether that's through mutual aid, through the creation of new community healing spaces that are virtual, and through coalition building. And coalitions have been really crucial in ensuring that there's equity and in ensuring that there is collaboration across those who are marginalized and those with more privilege to help to mobilize to provide the greatest care.
I understand we only have 1 minute left. So we'll just skip to the very last slide here. I think we've covered most of it already. It's just recognizing and naming again that our communities are disproportionately impacted due to identity factors and social demographic, that there are boundaries and limits to the kind of work that we do. And when you're passionate about this kind of work, you want to do a lot of it, and it's important to have your own boundaries around it. And making sure that that there's spaces built in for your own self-care around this, and that you're with others who can understand the nature of these events and be in communication with them.
And the last thing that I would say is just the importance of advocacy, that in a lot of the work that we do, yes, there's direct service provision, but also we're doing this work in conjunction with advocacy so that we can address the mental health needs of the most vulnerable populations, not just on an individual level, but also on a systemic level, which is very important. So thank you.
Thank you so much.
your presentation. So we're going to be calling up our next speaker. Give us a moment, please, to bring up her presentation. You guys can take a moment to like stretch it, like go ahead and stretch. It'll take us a moment. Take a deep breath, stretch. So our next speaker is Dr. Kaltam Jabor Alkuwari. She'll be discussing the relationship between psychological stress in the context of corona pandemic and the quality of professional performance of school social worker. Dr. Kaltam Alkuwari is an associate professor at Qatar University at the Department of Social Sciences, University College of Arts and Sciences, and she previously worked in the Ministry of Education. She currently writes a weekly column titled Iceberg Cater in the Al Raya. Dr. Kaltam?
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. My name is Kaltam Alkuwari. I am associate professor from Qatar University, visiting professor in Indiana University, IUSP, just for a few months. And on 1 April, I will back to my university. Thank you. Today, I will talk about the relationship between, between psychological stress and the corona and the pandemics and the quality of a professional, of social, of school social worker. So most people experience a state of panic, anxiety, and attention, and why the scout did not happen recently. A lot of studies found emotional and psychological problem, including isolation, fear, anxiety, and other mental disease. Social worker first shared the stress with their clients due to the spread of COVID-19, in addition to the preventing fear to affect with the disease or infection of a family member. What is the psychological impact of corona pandemic on the quality of a professional performance of a school social worker in Qatar? Objective of the study. The current study has two primary objectives. One, the level of psychological stress faced by school social workers during the corona pandemic in Qatar. Second, exploring the quality of a professional of the school social worker in the context of corona pandemic. A study the concept of psychological stress, the condition of tension, distress, and work and life imbalance from stressful events such as COVID-19, for example. School social workers might be affected by the stress of at personal and professional life as service demand increased and their ability to respond decreased. Study the concept. The concept of a professional quality, a set of specific duties and role that school social workers perform to achieve the school's goals. The pandemic has affected their ability to perform, resulting in not meeting school service goals. Study methodology, study design, descriptive survey, study total scale of psychological stress caused by COVID-19 pandemics. 5 personal stress, family stress, social relation stress and health stress, work stress, professional inequalities called their mention, personal dimension, or technical and administrative. Both skills were piloted for internal face value and people. Sorry, I'm a little tired because my journey is very long. 16 hours I fly from Qatar to South Bend to Chicago. From Chicago to Indiana because my son, he's 14 years, continue study and I keep him with, leave him and the family care him. And yes, back here from South Bend to Atlantic, I think, from Atlantic to New York, and take the car from New York City to here.
Dr. Kaltam, can I get you some water?
Yes, please, thank you. Sorry. For that, I have long travel. Study methodology, sampling a sample of independent schools under Ministry of Education and Higher Education in Qatar. All school social workers were invited to participate. Sample size. This study was conducted among 144 school social workers, government school. Time, date was collected, analyzed, and entered from the beginning of February to the middle of April 2021. Finding that table talk about gender and the gender male and female. Male 86, female 58, 40, 28%. Age under 30 years 24, from 30 to under 40 years 67, from 40 to under 50 years 35, and from 50 to under 60 years 18. Academic qualification, Bachelor of Social Work 104, and license of psychology 26, postgraduate studies 4, diploma, master degree 6, job grade, first social worker 15, second social worker 77, third social worker 52, and years of experience under 5 years 23, and from 5 to under 10 years 52, from 10 to under 15 years, 34, from 15 to under 20 years, 19, from 20 to above 20 years, 14. Thank you so much. You are very kind. Yeah, thank you. Study result that psychological stress level caused by COVID-19 is high among school social worker. Personal stress 3.42 is the level high, ranking 3. 2. Family stress 2.68. ST2143, average, level average, ranking 5, and social relation stress 2.96, 1884, average, level average, ranking 4. For health stress 3.87, 0.976, level high, ranking 1. 5. Work stress 3.55, SD2 163, high level, ranking 2. Finding contact. Psychological stress caused by COVID-19 had a negative effect on the school social worker. It led to some lack of motivation among social workers to serve student and school staff, lack of knowledge and professional skill to cope with the corona pandemics, lack of cooperation between teachers and social workers to their low awareness of role social workers played in the fight against COVID-19. The study result indicate that the level of professional inequality in the school social workers is low due to the virgin stress caused by corona pandemics. The personal of professional is 152, ranking 2. The technical 147, level low, ranking 3. 3. The 2.08 and level average and ranking 1. The study results indicate the professional performance quality school social workers favor according to gender only. The cause of this is maybe that male school social workers are most affected than female ones. There is a positive correlation between psychological stress and age among school social workers. There is relationship between psychological stress caused by COVID-19 and the professional quality of school social workers. Recommendation: providing awareness and counseling program to help school social workers, improving working conditions for school social workers to reduce the job skills improvement training for social workers in order to prepare them for future health crisis pandemics. Thank you for this wonderful scientific hosting. Sincerely yours, Kaltam Jabor Alkuwari. Email Alkuwari, KQUADUK, and for IU, ADU. Thank you so much.
Thank you, Dr. Kavari. So now I will invite our discussant, Amna Al-Sain. And then if you guys have any questions, go forward, please. Do you have any question? And Dr. Amna, if you can please unmute yourself.
Oh. Assalamu alaikum, everybody. I'm overwhelmed with too much information. The first panel, I want some of that coffee you all drink because that went very, very fast. And I missed the first 5 to 7 minutes of the slides. So I'm not sure what was on there, but there's some interesting things about discrimination of Muslim healthcare workers that seem to go back to school, to the residency match, and the turnover and issues with promotion. So I would like to use my little bit of discussing time to ask for some further elaboration. I'm not sure who talked about the residency matches, the problems with school, the turnover rates, and issues with promotion. Who was that? Santa, was that you?
Can we find a less unpleasant campsite next time?
Hello.
Hi, assalamu alaikum.
Walaikum salam, Mr. Speedy Gonzalez.
Yeah. Yeah, getting us both in frame is gonna be hard. But yeah, so thank you for that question. So I understand it's tough that we didn't catch the slides in the beginning. That's difficult. But basically, when we mentioned the various different adverse experiences that Muslim healthcare workers face, that was in sort of our background slides in which we were sort of setting the stage for the fact that Muslim American healthcare workers are at risk for a lot of different types of negative mental health outcomes. And some previous literature has explained that a result of things such as discrimination or implicit biases from peers or from administration.
How does this discrimination happen? What do they do?
So on some of the literature review, a lot of it was taken from Western culture, including like Britain as well as America. There was anecdotal comments made by Muslim healthcare workers stating that just the social construct of the West has led to discrimination in terms of social outgoings that revolve around alcohol. There was a lot of discrimination against hijabis and just prayer spaces, and they felt the disconnect with their coworkers. This really led to them either thinking of other job opportunities or not being able to go further, like being promoted in that space.
how are they discriminating against? How? Give me some on the ground how. Not
Yeah,
calling
so
on what?
yeah, so in our study, we just kind of assessed it based on self-report items, which is a big limitation that we tried to address towards the end. At the end of the day, what a person interprets as a discriminatory experience is what we were trusting in our analysis. However, there is previous literature that gets into a little bit more detail. So I wouldn't mind. I guess I could follow up with you, and I could share with you some of the previous literature that we
I just
cited
think, you know,
as just background.
discrimination is a big word, and people need to know how it's manifested to get to people's feelings. And you also talked about coping strategies, and you talked about healthy religious coping strategies and unhealthy ones. What are they?
Yeah, so when we were discussing our cognitive coping strategies, we basically surveyed the literature to see if there was any existing precedent for measuring different religious thoughts and different religious behaviors. And so we have found some scales that have already been validated that incorporate some of these things. So for example, some of our thoughts that we assessed were looking for a lesson from Allah in a difficult situation, or trying to remember the blessings of Allah and thank Allah was another one. And this is something, these were thoughts that we had explicitly asked our participants, and they reported how often they agree with those, how often they have found themselves utilizing that coping thought.
So what were the unhealthy religious coping strategies?
I could reshare the slide if you would like. I can try to find that. Is it still open in the thing? Oh, yeah, we could open it because it was so when we were presenting them. Yeah. So I could try to remember them, but that'd be kind of. Yeah. So yeah, we'll try to pull it up so you can see the spread.
Okay.
I think if you should, I should be able to find it if I just search my name. I can
This is yours. Sorry, one moment. You can keep explaining if you want until I get that up there.
Yeah, I'm not sure.
There it is.
They tell me that young people are supposed to be experts at IT. Come on now.
Not this young person.
Yeah. Actually, I'll go to the regular slide.
And then also screenshot this.
Yeah. Okay. Okay. So we're gonna start sharing the screen now.
Okay.
So we will see here. Are you seeing everything?
Yeah.
Yeah. So this was the spread. Yeah.
So you're labeling losing my faith in Allah's wisdom and compassion, which a lot of folks at the end of war or other kinds of traumatic events talk about. And then curiously wondering if I'm being punished. Say something to me.
Yeah, so I think it is a very good point to identify that these are pretty difficult thoughts to be having, and I guess to label them as like specifically unhealthy in quotes was sort of a generalized term for effectively like when you experience stressors, how does that impact the way that you are perceiving and interpreting your religious beliefs? And so we were kind of just generally putting them into two groups. For ones that were generally supporting your religious beliefs, which we kind of were hypothesizing that would kind of add on to the ability to utilize other healthy coping strategies that might have been more behavioral. Whereas more negative thoughts will be things that are sort of related to distancing yourself from beliefs and distancing yourself from religious identification, or identification is the wrong word, but distancing yourself from those things, which we were hypothesizing would result in like less access or less utilization of, or be associated with less utilization of other healthy coping strategies from the religion.
In this, not in this particular slide, but do the members of this group think that um, the restrictions on religious congregational, quote unquote, practice, not being able to be with Muslims outside of the family, really heighten their thoughts about getting COVID and dying if they were in contact with the people they serve.
Yeah, that's actually really interesting. So that was actually part of the impetus for us not utilizing a full psychometrically validated scale that we did find in the
Slow
literature. Sorry. So we were able to find a scale in the literature that identified, or that sort of assessed religious coping from a Muslim perspective. And in that were some cognitive thoughts, which influenced the ones that we wrote, and also some behavioral activities related to religion. And one of the reasons why we weren't able to utilize that full scale was because it incorporated some behavioral things that were restricted as a result of the pandemic, such as attending religious services. And so we definitely think that that's one thing that was very relevant to people's negative psychological outcomes. However, we weren't able to specifically assess that really in this case because it was restricted. So yeah, we definitely think that factors in, but we weren't able to explore that explicitly.
Well, I loved your list of things for future research, and I pray that the group stays together and keeps doing the research, because I think it's very, very important, not only for the field, but also for the Muslim community. So I thank you for that. And let me turn to the double edge. The thing that struck me most was the fact that both Tahirah and Shamaila, am I pronouncing it correctly?
Abdullah.
Huh?
Shamaila.
Shamaila, as two women of color approaching all of this. Shamaila, I couldn't hear you very well, but I heard enough. And one of the things that stood out to me was, how do we get clinicians and practitioners and allies on the ground to see and feel what's really going on? And the double edge really hit me with mistrusting the system for the African American, Latino, and Hispanic communities, where they have had direct contact with the healthcare system, which has not served them well. So they were very, very hesitant. And you didn't talk much about this, but I'm asking now, very, very hesitant to, oh no, you're not shooting me with anything. You know, last time you shot some Black folks, we ended up, or you withheld other medicines, and there was some withholding with Regeneron and some other alternative treatments. We wound up, you know, on the creek without a boat or a paddle. So I wanted to know from you, in your putting both feet in the community, I know you heard the same things, but how were, or if you were able to convince people of a necessity?
Thank you for that question. For the first part of it, I think, you know, being in the community and being on the ground and doing this work, before I get to the double edge, I think, you know, our psychology or mental health field is very Eurocentric, and the idea of providing services within the clinical room is what's familiar to most. And I think we need to step outside of those frameworks and expand those, especially when we're working from multicultural diversity perspective. Having that awareness makes it important for us to sort of step outside. We have one, you know, foot in the clinical room, but then also being able to step outside has been meaningful and important. So that's one part of it. As in regards to the second part of what you're mentioning, yes, those were experiences that we heard. I remember hosting a listening session, and many of the people in in the organization were wanting to actually quit because they were not vaccinated and not opting to vaccinate. And what institutions do in response to crisis situations is that they become very black and white. You do this or you don't do this. Without understanding the complexity of reasons as to why one may be resisting that. So what we did was open up the space for them to talk about what the resistance was about, and then take that content back to the agency and say, maybe you need to approach it this way. And I think it was important for them to hear that we identify as those individuals as well who have had our own thoughts in this similar regard. But what made us then consider getting vaccinated? Acknowledging the historical impact of experiments that have been done on the Black community and why there's a mistrust. It's understandable.
Well, also, before I get to Tahirah specifically, in the South Asian community, there was a hesitancy and a refusal to take the vaccine for a number of reasons. We have herbs in our food that can, that boost our immunization status, and all kinds of interesting rejoinders as to why they would not take the vaccine. Give us some insight into, because they hadn't had the same kind of experience with the U.S. medical system.
Yes, you're absolutely right. They haven't, but I think just hearing those rationales on a subjective individual level would help us sort of sort out what their reasons were and what their hesitancies were about to be able to tackle them. And I think just the idea of having somebody from a similar background listening to you, the information is just received differently. And I think that's a big part of the process of the work, and being able to hear multiple perspectives where they then get to decide. Rather than the black and white idea, like you need to do this or that, and what's right and wrong, so to speak. So that.
And your community, more than the African American community, had people with different immigration status, and whether they were some here illegally and did not want to give up information in order to get vaccinated. They thought they were going to have to turn over their life story and therefore be disclosed. I mean, their immigration statuses be disclosed. So we have lots of double and triple edges going on.
Yeah.
Tahirah, you gave the thing on the mistrust of the system, and that became critical because now we have, and I don't know what the name of it is because I can't keep up, another variant roaming. And people are tired of masking, those that even bother to mask, and social distance has become a foot away. So what are you going to do on the ground?
Yeah, thank you for that question about what to do on the ground as it relates to balancing the mistrust, and I think which goes hand in hand with misinformation.
Yes.
Yeah, and the need for safety. In 1 minute, I think the main thing that I would say is really important is trust goes both ways. And I think it's really important for medical professionals in the government, to trust that the public can handle the truth and the reality of what the situation is, and to be transparent about that. And I think to the extent that that can happen, that can work towards building trust, and can help people to actually, believe that when, they say a mask is necessary for this reason, that it's understood that a mask is necessary for this reason. And so I think that that's a big piece of it, in addition to just kind of working together to keep each other safe.
Thank you. Sana, do I have a chance to get to our last participant?
I wish we did, but we do not.
Okay.
And also we had a couple questions in the audience. So we can just direct them directly to the presenters or speakers with the Whova app, or if you see them in person. I know I have a question, so I'll just find you guys later.
You don't count.
And also, thank you, Dr. Al-Deen. Also, I'm going to put up the CME, the event code, so you can get your